Well, welcome back, friends, to this episode of season 2 of Test Those Breasts. Can you believe it? Season 2. I have been, doing this podcast for a little less than 8 months, and we are on season 2 now. And today I am super excited and honored to have Dr. Garza on my show. And so Dr. Garza is a plastic surgeon in San Antonio, Texas. He has spent the last 7 years of his life dedicated to treating and helping breast cancer patients. He is an expert in microsurgery, breast reconstruction, and performs these surgeries twice a week. Dr. Garza is the founder of Dr. Garza Plastic Surgery, which he opened in February of 2022. Well, welcome, Dr. Garza. I am so excited that you're here, and I'm always on the lookout to connect with amazing surgeons and other providers around our country and even the world, because when I had to make my own decision to get breast reconstruction and the surgery, I didn't even know what to do. I didn't realize that there were different types of surgeries that I could do. So being on Instagram has really helped. And that's how we ultimately connected. And then, of course, which was really cool, is that my own surgeon, Dr. Cabling, heard that I was going to interview you because I had mentioned him to you. And it turns out you guys have a lot of respect for each other. And there's more to it that we'll dive into a little bit later. So welcome to the show. How are you doing today?
Thanks so much for having me. I'm great. We had a busy week this week, hit the ground running for 2024, but thanks for making time in your schedule to have me on.
Yeah. Well, I kind of stalked you a little bit, not in a weird way, because I wanted to get to know you a little bit more before I had a conversation with you. So I Googled podcasts and Dr. Ramon Garza, and I ran across your very first episode that you ever, recorded with someone, and it was on YouTube.
Mhm.
And it was really actually very fascinating to listen to because, um, first of all, you talked about your younger years in your education realm and how you were in the gifted and talented program. And I, for the last 6 years of my teaching career, taught at the gifted and talented magnet schools here in Reno, Nevada. And
Mhm.
so as I was listening to you about how you became a better learner,
Mhm.
you reminded me of some of my students. And so that was just really cool. And then we talked about it a little bit. So, but then I was really looking for how it is that you actually, like, how do people just fall into this line of work? So
Yeah.
I'd like to start with that. How can you share how you got into plastic surgery, and more pointed at how you got into microsurgery and breast surgery?
Yeah. Happy to share that. So when I was in college, I kind of knew I wanted to go into the medical field and was interested in becoming a physician. And for my undergrad, they had a summer program where you had the opportunity to take summer classes and prepare for the MCAT, which is the entrance exam that we take before going to med school. And as part of that program, we had the opportunity to shadow a physician. And it was kind of random luck. Most of my colleagues, my classmates, were scheduled to shadow a primary care physician or pediatrician. Which my initial, I didn't know anything about medicine or anything. I was thinking, oh, I like kids. I'll be a pediatrician. That's kind of what my general feeling was. But again, I didn't know anything about medicine at the time because I was only a college student. But by sheer chance, they had me shadow a plastic surgeon for the summer at University of Texas Medical Branch in Galveston, UTMB. And that was my first exposure to plastic surgery. So I had to contact this person. I paged the physician I was supposed to shadow. I met him at the nurse's station, and he's like, "Okay, let's go, grab lunch." And we went to get lunch, and he's like, "Okay, we're going to the OR." So that very same day where I met him, where he's taking me to surgery, and I'd never been in the operating room. I'd never seen a surgery before. I was a bit nervous, as you would imagine. And but when I walked in, I saw what they were doing. I was just like enthralled and just completely amazed at what types of surgeries they could do and what they were able to do for patients. So I kind of had an inclination to pursue a plastic surgery training even before med school, just from that one experience. And then in med school, I liked all the things we learned about in medicine. I liked, learning about the heart, the lungs, the physiology. But the things that really grabbed my attention and really I felt were my calling were something surgery related. And when I, again, rotated back through the plastics and had that exposure again, I was like, this is where I need to be. This is the field that I think is going to be the fit for me. And thankfully and luckily, I was able to get into that training program, because it is a very hard program to get into plastic surgery.
Well, I would imagine so. And I mean, it's such an intricate, very complex types of surgery. And so it should be a little hard to get into there, I guess, right?
Yeah.
If I remember correctly, you talked about when you were brought into the OR, you were kind of like, whoa, wait. Did I remember you saying something like, I don't even know if I like blood or whatever it is. Or,
Right. Yeah. You have a good memory. You have a very good memory. Yeah. That was so I'll never forget. We went to the cafeteria. We had like a fish and like cream spinach and some like kind of a heavy lunch type meal. And I was just expecting to like meet him, introduce myself and then call it a day. But we had this heavy like lunch meal. And he's okay. We're going to the OR. And I remember like getting very nervous. Because I'd never really seen blood before. I'd never seen a surgery before. So I got very nervous that I was going to like pass out or throw up or something, especially after eating this cream
yeah.
spinach type meal. But like, again, when I walked in, I kind of saw what they were doing, like all those feelings of like nervousness kind of, subsided. And I was just overwhelmed with what they were doing and just really interested.
Yeah, now look where you are now. There's blood everywhere, right?
Hopefully not. We like, as
Okay.
microsurgeons, we like to maintain a bloodless field, and we try to lose as little blood as
Okay,
possible.
maybe not everywhere, but just right, like there's a lot there, right? Anyway, well, yeah, I just thought that was so funny. I was like, okay, now he's a surgeon. He sees blood every day, right? So breast reconstruction, I have been meeting some really, really interesting breast surgeons. We breast cancer patients and survivors and thrivers we're on all of these, support groups like the
Mm-hmm.
New Orleans support group. We're on Deep Flap. Yeah, there's like 4 different ones I'm on.
Mm-hmm. Mm-hmm.
And we see a lot of conversations going on. And so we who have been to the best of the best, like I know that I have been, Dr. Cabling, as you know, is an absolute magician, really.
Mm-hmm. Mm-hmm. Talented.
I know the questions to ask now. Going back to before I got breast surgery, when I found out I had to have mastectomy, I was absolutely devastated. So I was in a place where so many women are right now, and will be coming up to that situation soon or whatever. But
Mm-hmm.
I remember that fear, and I remember thinking to myself, oh my gosh, we women are so connected to our breasts, I mean, that is such an important part to us. And so we have to mourn the fact that we have to lose our breasts.
Mm-hmm.
And, no one can understand that unless you're in our situation.
Mm-hmm.
And so when you find out information like that, of course, your local surgeon is going to say, okay, here's what we're going to do, this, and this. And that's what happened to me, is that she says, okay, we need to take your left breast and then we'll get you to the plastic surgeon, blah, blah, blah. Luckily, I don't know if I told you this story. Luckily, due to kismet, really, I call it, I had 3 totally separate friends of mine reach out to me and say, hey, Jamie, I have a friend of mine who went to this place in New Orleans. She actually had implants before, and she went to New Orleans to get them explanted. And then she had this kind of surgery where they take the tissue from your body. And then I had one other person said, hey, my sister-in-law went to this place in Alexandria, or it was in Washington, D.C. area. And then another one went to New Orleans. So 3 totally separate friends talking about this kind of surgery that they can reconstruct your breast with tissue.
Mm-hmm.
And I'm like, okay, something is to this, because we don't have that in Reno. We just have implants. Now that may not necessarily be that a surgeon doesn't have something like that on their menu, but they are certainly not microsurgeons.
Mm-hmm.
They are not people who have done hundreds and hundreds and hundreds of these kinds of surgeries.
Mm-hmm.
So I call myself incredibly lucky that I was sort of at the very last minute steered into a direction that I went into. So now I'm on a mission to make sure that people understand that there are options out there. They may have to travel, but I want to know where the best of the best are so that
Mm-hmm.
people can have these kinds of options. So that being said, we need to know, why is this surgeon so interested in breast surgery for breast cancer patients? And I'm just curious, why is that something that you gravitated towards?
Mhm. Yeah, those are all very important points that you brought up with the patients, coming, especially when they come to the plastic surgeon's office. Oftentimes they're like so overwhelmed, like information overload. They've seen their oncologist, they've seen their surgeon oncologist, the person who's doing the mastectomy, they may have seen a radiation oncologist. So by the time they get to the plastic surgeon store, it's like, I'm on information overload. I don't even know what questions to ask you. And sometimes even during the consultation, they're like, a little lost. So um, getting some information beforehand is super important, and people that do what you're doing and having information available for those patients, I think is a tremendous service to the breast cancer community. So thank you for what you're doing, because it's very helpful. I have patients that have come in for the consultations and they've done the research and they know what questions to ask, and when I discuss things with them, they have something to hang that information on because they've already kind of been prefaced with some baseline knowledge. So it's very helpful when we have that complex discussion about breast reconstruction. But to your question, why did I choose breast reconstruction surgery as my primary focus? I am someone who likes kind of detail-oriented type things. In my training, we had exposure to general surgery and CT surgery and all kinds of things. And the two things that I liked most were probably cardiothoracic surgery and plastic surgery, specifically microsurgery. I really like the fine dissection that microsurgeons do when dissecting out blood vessels and connecting blood vessels and doing just very delicate, neat anatomic dissections, and that type of surgery really appealed to me. And in addition to that, we do that, right? We do the technical part of the dissection and the blood vessel sewing, but then we also have the artistic part. And that artistic part is recreating a breast mound that's going to look beautiful and have our patients happy. To me, it's the most rewarding thing that we do in plastic surgery is something like this, like a reconstructive type surgery. And for me, it's breast reconstruction. So that's it. Those two things of the detail-oriented, microsurgery part, artistic thing that's like the perfect fit for my interests and what I feel that I'm good at was breast reconstruction.
Now, I sort of had thought of a question while you were explaining that. Um, I don't know whether you have breast cancer in your family or anything like that, but when you when you do like first and second phases for women and you've seen them go through this whole process,
Mm-hmm.
how has that changed your thought process and emotions about what you actually do for women? Because it is a very emotional journey for women.
Mm-hmm.
And when they have a solid relationship, like that a doctor patient relationship, because of what that doctor is doing for that woman, it's pretty profound. Like
Mm-hmm.
I know that you did some of your education with Dr. Cabling,
Mm-hmm.
and we'll talk about that in a minute because I really am fascinated with that. And it makes me know that what kind of doctor you are, because I actually did mention your name to him when I was just there a few weeks ago, when I was doing my pre-op before my second phase deep flap surgery, and he had nothing but wonderful things to say about you, and you've had really wonderful things to say about him. It's that human connection that I think makes it so much better. So your human connection with these women and men, and I do want to talk to you a little bit about that too, because we can't leave men out,
Mm-hmm.
and because they get breast cancer too, and we need
Mm-hmm.
to know that. But that human connection that you have with your patients, has that changed a bit over time because of what you do?
Um, I think the way it's changed is my approach to patients, and I've just gotten better at it. I've always kind of felt the same way about those patients that are going through that, breast cancer journey. I've always had, compassion for these people that are, a lot of times just super overwhelmed, and it's a devastating thing to have to go through. And like I said, a lot of times when they come to us, they're just like, at, their rope's end of like, okay, I can't handle anymore. Like news, be it bad news or good news, like just help me get through this process. And oftentimes I'll tell people like, you and I are going to be friends for the next year because it's a journey. It's going to be a year of kind of getting through this process, but we're going to get you through, and I'm going to hold your hand and kind of, let's take a breath and take a step back and like look at the big picture. You're starting at point A. We're going to get you to point B, but in between, there's some little steps you have to get through to get there. So I think that, it doesn't really change how I feel about it, but I think my approach, with experience and having lots of these conversations, multiple times a day with patients, I think it's just changed my approach really.
So that tells me that possibly you have a philosophy of that shared decision making
Oh,
with
absolutely.
your
Yeah.
patients. Yeah.
Yeah. I think the era of kind of that, paternal, like, oh, patient comes to the physician, you're getting this, and that's the end of it. I think that's a bad way to do medicine. And I think that kind of era is kind of going to the wayside as kind of a newer generation of physicians. And through experience that we've had with our own patient interactions, we're learning from our experiences as a physician group and as plastic surgeons. So I kind of view myself as an educator. When a patient comes to the door, my new patient consultations are 1 hour. So, and I oftentimes go over that just because there is so much information to cover, and I want to cover it in a way that my patients understand it and not use complex language. I draw pictures so that things can make sense. I pause and stop and make sure my patient doesn't have any questions and ask them like, does this make sense that what we're talking about? Because we're talking about some complex issues and a lot of information has to be processed. So I think like with that approach, uh, patients being educated is the best way so they can make a good decision for themselves, and I'll help them along the way. But my role, the way I view myself, as an educator, so that patient can feel empowered to make a good decision.
Right. That's awesome. I didn't learn really what the term shared decision making was until I interviewed Dr. Crisopolo a few months ago. And he said that that term really isn't new. It comes really from the 80s, um, which was when I was in high school, by the way. Um, but anyway, just us talking about this is so funny. My husband and I were watching the movie Maestro last night. I don't know if you've ever seen that title, but it was a really good movie, and I won't go into obviously what it was about, but there was a scene in there when the husband and the wife were sitting in the doctor's office, and she was in her gown, and I videoed it, so I'll send it to you. It's great.
Yeah.
And the doctor plows in, sits down, pulls himself up next to her, and he says, "You have breast cancer and it has spread to your lungs. And now what we need to do, I know, but what we're going to do is we're going to take your left breast and we're going to do chemotherapy. I don't, he went through all the treatments that he was going to do. And then
Mm-hmm.
we're going to do this, and then we're going to do this. And I can have it done within the next couple of weeks. Okay." And I was like, he just came in and told her, and she's like, whoa, 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 what?
Mm-hmm.
Wait.
Mm-hmm.
And the husband's sitting there going, yeah, okay, that's fine. And she's like, wait, what? So it's just different now. And we can recognize the difference between that kind of, provider who does something like that and somebody like you with a shared decision making. So I'll send that to you because I thought it was very fitting, right, to what we're
Mm-hmm.
going through
Mm-hmm.
here. Okay, so can you share a little bit about your experience working with Dr. Cabling?
Yeah, so I know Dr. Cabling from my fellowship. I did a microsurgery fellowship, as most of us who do this type of surgery do. We do microsurgery fellowships in breast reconstruction. Those of us that are interested in that type of field will typically do that after our plastic surgery training. So that was the field that I knew I wanted to go into. I wanted to get, the best experience. And so I went to Ohio State, where they do a high volume of microsurgery there. And as part of my experience, I worked with Dr. David Cabling, who was a young attending at the time when he was there. But I got, opportunity to work with lots of different microsurgeons, but I would say probably almost half of my experience was working with Dr. Cabling. He and I did a ton of microsurgery together. So we had an awesome time in the OR. He and I operate in a kind of, I think we talked about this, in a kind of similar fashion. Our presence in the OR is usually, the team is, I think, at ease with the way we do surgery because things flow very, very easily. There's not like a high tension situation usually. Those of us that are surgeons know certain type of surgeon personalities where they, when the typical surgeon personality you would think of is like the surgeon gets angry, throwing instruments, yelling at the staff. That type of personality still exists, by the way. But Dr. Cabling is not that personality, and I'm not that personality either. People who work with me know that I just try to be friendly, make sure that the staff feels comfortable. Because when you have a team that's comfortable and is not feeling threatened or feeling inferior than, or any of those feelings, they just work better together. Like when we're in the OR, it really feels like team, and we're all on the same mission, make sure our patient gets the best care. And I think that's the philosophy that he and I share.
What a concept.
Mm-hmm.
All workplaces should be like that. That's really amazing. So I want to get into a little bit about breast reconstruction with a lot of women are told from their surgeons, wherever they are, that they are not candidates, for DIEP flap or whatever, any kind of autologous surgeries. And then they go somewhere else and say, well, that's not true. They are candidates.
Mm-hmm.
What is well, I guess what I want to start with is, what is your experience with working with people that have a low BMI and those who have a high BMI?
Yeah, I have tons of experience with low BMI patients. I've had a ton of patients that I've done over the past 7 years who were considered not candidates for whatever reason, and it really comes down to the patient's preference. Because certainly, if somebody has a low BMI and their goals, like one of the very first questions I ask patients is, what are your goals for your desired breast cup size? Do you want to be the same size, smaller, or larger? So I have somebody that comes in with a large breast and they want to maintain a very large volume, but they have a very small amount of donor tissue available. A autologous tissue, be it a DIEP flap or other flap option, may not be the best option for them. So it's not that they're not a candidate, but it may not be the best option for that particular patient. If I have another patient that has same situation, but is okay being smaller and does not want implants, that person obviously is a candidate because I can do the surgery. I can give them a shape that I think will look nice for them. And the other thing is, having lots of experience with these types of patients, I have a large portfolio of patients that I can show pictures and say, this is a patient that I did who is similar body type to you. This is an expected type outcome for someone of your body habitus. And so the patients will look at things and they're like, okay, yeah, that's not acceptable to me. Or, okay, I understand what you're saying and what the limitations are. I'm okay with that. So, but drawing on those experiences is very important. And adding on to that, sometimes patients are concerned or they've been told by other plastic surgeons, I'm not a candidate for this procedure because I've had, liposuction or I've had this abdominal surgery. The only surgery that would be an absolute contraindication for using a DIEP flap would be a full abdominoplasty. I've even done a DIEP flap in somebody who has had liposuction to their abdomen and a mini tummy tuck. Mm-hmm. So they did not have a full tummy tuck. That's the big take home point is the full tummy tuck. Absolutely, you cannot use a DIEP flap. Maybe there's other options for autologous tissue, but certainly not a DIEP flap. But you can do these surgeries in complex settings if you know what you're looking for, if you've had, obviously experience in doing these types of things. So I think going to an experienced microsurgeon, plastic surgeon is important. And if your plastic surgeon who's doing your breast reconstruction is not at least discussing these options, even if they themselves don't do it, they should be comprehensive and discussing them in a way that is upfront and I would say I wouldn't say honest, but just very transparent about what those surgeries entail. Because oftentimes surgeons who don't do these microsurgery breast reconstructions will kind of poo-poo the surgery and say, "Oh, that's a very long surgery. It's a very long recovery." When in reality, that's not the case. It's usually one extra day in the hospital, and recovery time for both implant or using your own tissue is about 4 to 6 weeks. So just because that plastic surgeon doesn't do it and they kind of dismiss it, it's not necessarily the right way to approach it.
Well, and I have learned a few things about why some surgeons say the things that they do. I have a wonderful surgeon here in Reno, and I love her. She's wonderful. When I came to her about asking her about the deep flap surgery, I said, there's this surgery you can do. And her response to me was, well, I don't really know much about that surgery. My only concern is that there's no local care. And there was no other discussion beyond that. And
Mm-hmm.
I wish there would have been, um, even if it was, let's find out about it. Let's see if this is something that would be good for you. But that didn't happen. But I did find out that sometimes if they don't have the experience with that kind of surgery or even know anyone who does that surgery, they will sometimes kind of poo-poo it. That's why I always say, get a second opinion,
Mm-hmm.
call other surgeons, even if it's outside your realm, your area, get on some support groups and things like that. So, because I can't tell you how many people I've heard say, "Oh, I didn't get that because I wasn't a candidate." And I'm like,
Yeah.
"Well, why?
Mm-hmm. Mm-hmm.
What was the reason?" And, "Oh, I didn't have enough, whatever." It's like, okay, now I know a starting point. How can I, um, yeah, direct people into finding out more before they
Mm-hmm.
make the decision that they make? So
Mm-hmm.
I didn't want to do the implants, but, um, what
And
are your, oh, go ahead.
I was going to say, and patients need to be their own advocate. They need to like
Yeah.
look up things, do some research. Like there's so many online support groups and ways to get good information. And if you are in an area where you don't have this as an option with a local surgeon, so many of us that do these procedures also do virtual consultations. If there's one good thing that came out of COVID was the ability to do telemedicine, and people feel comfortable doing telemedicine. So a lot of us that do breast microsurgery, breast reconstruction, have patients that come from out of state and
Mhm.
travel for their surgeries.
Yesterday, what did Dr. Potter said? She said something about women speaking up for themselves and being okay with it. And I'm trying to remember exactly what she said, Dr. Elizabeth Potter. And I
Mm-hmm.
said, like, I am a pain in the neck. And I'm proud of it. I ask questions and I don't care what other people, anybody, oh, here it is. She said, she said, be difficult or something. And I said, thank you for this. I said, I'm difficult and proud of it because I ask questions and I try. And there's so many women who are really, they don't have that strength yet. They don't have the voice yet. They haven't found that voice. And it's not to be a jerk. It's just to ask questions and advocate and get a second opinion and be okay with it.
Yeah.
Right. And I think that providers need to be okay with their patients getting a second opinion too, because half the time they'll come back and say, oh, well, they said the same thing that you did or whatever. So, okay.
I'll give you a little anecdotal. I've had personal experience with this because anybody who's a parent may have that, going with a child who's been sick and trying to go through the medical, treatment route with as a person who's in medicine, and then being on the flip side, being a patient, or our daughter was born premature, so she was in the ICU, and we had to I had to flip hats and be, patient dad versus, being medical provider. So, asking the questions, not being rude or anything, but just asking questions, making sure that my daughter is going to get the best care. Me and my wife were very involved in like all the decision making, and just didn't take whatever was said, as gospel. We would like, okay, no, why is this, and ask the questions. So I think as medical providers, we should be okay with that and not feel. I never feel threatened by patient asking questions or why are you doing it this way. I think it's
Right,
important.
because ultimately when they go into the procedure, they're going to feel so much more comfortable and knowing that you even care that they got all of their questions answered.
Mm-hmm.
And I just feel like that's a better way to go about it. There are a lot of people who are concerned about radiation. So what are your thoughts about an experience with radiation with breast reconstruction?
Yeah, so radiation, that's a great question. Radiation, I always tell patients who are going to get radiation, it's like you can think about radiation like a sunburn, but the sunburn goes all the way down to your bones and into the chest wall, the deeper structures. So unfortunately, it kind of forever changes the structures around the chest, and it will always um, affect those tissues. So, having said that, when you're going to have radiation with reconstruction, the question becomes timing of reconstruction. And with the new advances in the way we deliver radiation therapy, and goes back to having conversations with your providers, right? This is a conversation to have with the radiation oncologist. If you're going to have an immediate reconstruction and have that immediate reconstruction radiated, you want to know that your radiation oncologist has experience radiating reconstructed tissues, specifically flaps, or if you're going to have a radiated tissue expander, what their protocols are, what their experience is with that. But as plastic surgeons, we have to offer, I think, that as an option for a patient to have an immediate reconstruction and have the immediate reconstruction radiated, just so patients can make an informed decision. Because a reconstruction as a delayed reconstruction after radiation looks very different than an immediate reconstruction, mostly because of the way the skin paddle, the skin island of the tissue that's left on the chest wall looks very, very different. So I think, showing pictures worth 1,000 words, but having patients see before and afters of delayed versus immediate that's been radiated and how that looks, I think is the best way to approach that situation of needing radiation. And there may be some patient factors in which case the patient is not the best candidate for immediate reconstruction, and they'd be better served as a delayed reconstruction after radiation.
Yeah, it's a really good point that you brought up, that your oncologist should have experience with radiating reconstructions like that, because, and I know that radiation options have changed. I don't know a ton about it. I do know that there are options where you also don't have to get as many days of radiation, like,
Mm-hmm.
80 days or whatever,
Yeah.
30, 60
Mm-hmm.
days every day, Monday through Friday. I'm hearing that there are options of these 5-day or one time, and I don't know the circumstances, and I'm learning more about that because it's very fascinating to me.
Mm-hmm. Mm-hmm.
But I like that you made that connection, because I think a lot of people need to hear this, is that if they know they're going to have radiation and they're talking to their surgeon, how can we direct those patients to ask their oncologist, what kind of experience do you have with radiating these kinds of breast reconstructions?
Mm-hmm. Mm-hmm.
And so more information on that would be great, because
Absolutely.
it's just such a complex, and knowing the right questions to ask. So yeah, thanks for bringing that up. Um, what is phase two? Where's my question, Dr. Garza? I just lost it. Phase two, what does that look like? I know that in the breast cancer, people who have had, mastectomies and reconstruction, we know that the first phase is we want to make sure that the flaps are surviving
Mm-hmm.
and the blood vessels are all connected and doing well.
Mm-hmm.
And then we always say phase two is when they make them pretty. But what I
Mm-hmm.
will say is that if there is a really good plastic microsurgeon like I had, um, phase one, they looked pretty good. I will
Yeah.
say, after just phase one, I was pretty impressed. I mean, at the beginning, it was kind of scary, but as time went on, and I'm glad I waited an entire year to get my phase two. But I will say that I was pretty happy with what I had. And I told Dr. Cabling that, hey, if I could never have phase two, I would be okay emotionally and
Mm-hmm.
physically and all of that. So so can you kind of explain what goes into phase two, why it's necessary, and
Mm-hmm.
how it's different for some people? Because I know some people come to you that have had maybe implants and they get explanted and they've got different situations
Oh
going on.
yeah.
So it
Mm-hmm.
may not just be 1, 2 phases and that's it.
Mm-hmm, mm-hmm. Yeah, so for the uninitiated, phase one surgery was the initial reconstruction with either an implant-based reconstruction or which phase one would be a tissue expander in that scenario, or an autologous reconstruction like a DIEP flap where the mastectomy is done and the reconstruction is done at that same time. Or if you have a delayed, bring the tissue up, create the breast mound. That would be considered phase one surgery. Phase two surgery is when we do the touch-up surgeries to make them look pretty. But
Okay.
you hit the nail right on the head with Dr. Cabling. Those of us that do this surgery all the time, the goal is to make phase one look beautiful. You want to approach phase one because that's the footprint, right? You want to have a very nice starting point so that when you do phase two, if the patient wants phase two, this is again, the quote unquote shared decision making. Not all my patients want a phase two. Some of my
Right.
patients are happy with their phase one result and they're ready to move on with their life. They don't want to have another surgery and downtime and time away from work or
Yep.
family or et cetera. So setting up a good phase one, either it lends itself to a chip shot at phase two or skip phase two altogether, which either way, I'm fine with whatever makes my patient happy. But phase two surgeries, the things that can be done, oftentimes include fat grafting to the breast, particularly in the upper pole. A lot of times with autologous tissue and with gravity, the upper pole tends to lack a little bit of volume.
Mhm.
So we use the fat graft that we obtain via liposuction as like icing on a cake. We can't make an entire cake out of icing, but we use it to kind of smooth out some edges, recontour areas that may not be contoured to our liking, but at the same time with adding fat in those areas that we need. But the other thing I like about phase two is the ability to do liposuction at the donor sites, particularly the abdomen, the waistline, the flanks, and really shape the waistline. I think that's such an opportunity to give a patient a beautiful, beautiful result that looks like a mommy makeover type result with a good liposuction and doing it in an artistic way that gives them a really nice result.
Yeah, that's a really good point because if I look at my before and after pictures, that's what Dr. Cabling did is he did some lipo from the back, um, and he pulled my scar all the way down because I had developed this hardened little lump in my stomach, my lower belly,
Mm-hmm.
and I didn't know what it was, and he wasn't quite sure, so we did like an ultrasound, and anyway, ultimately what he did is he pulled the whole scar down, which did flattened my stomach. My curves are there, and he did fill in right up here because what happened to me is it got a little concave on a
Mm-hmm.
couple little areas, and so they're just filled, and my incisions after just 2 weeks post-op are very precise. We women share our pictures with each other with no head, with no head.
Right. Yeah.
And I mean, I can't tell you how many people are like, holy cow, the incisions are just so precise. And it just looks amazing. And then he did a little lift. So I can see the difference between my last ones and this one, where it was just a little bit lift, same size, just filled in a little bit and feeling great. But again, to your point, some people don't want to do 2 surgeries. So if you are going to the right surgeon, if you're asking the right questions, you're looking at their portfolio, if you are talking to people who have been to you, and I've seen pictures, I know you have a really good reputation. And especially not only from women that I've spoken to, but also from 2 different surgeons who also have a rock star, reputation, like Dr. Elizabeth Potter and Dr. Cabling. So, and I love that you guys talk highly of each other. That really speaks to who you are as a surgeon. My biggest goal is to be able to help people understand where they can go.
Mm-hmm.
And for some people, it's like, I can't travel all the way to New Orleans. I can't do, and so there are options in Texas, options in Louisiana. And I'm really trying to seek out the other places
Mm-hmm.
for people to do that. So, because there's plenty of people who are going to need that surgery, unfortunately, because there's so many people who get this breast cancer,
Mm-hmm. Mm-hmm.
pretty scary. So implant, we were talking about implant reconstruction. There's this talk about people getting implant illness. I I know people who have talked about that and who say that they've had that. What is your experience with that? Is there any such? I mean, how does that happen?
Yeah, it's kind of a poorly understood, illness that patients. It's there's research ongoing about this, and there's if you look, talk to 10 different plastic surgeons, you'll probably get 10 different answers about this. But basically, some patients feel that their implants, be it silicone or saline, is causing an inflammatory process in their body, either creating an autoimmune issue or just general feelings of not feeling well, kind of fatigue, vague type symptoms that are kind of hard to pinpoint. My feeling about it is I've had patients who have had symptoms of BII. They have their implants removed and they feel better. Whether or not that's a placebo effect, I don't know. But I have had experience with patients who have had that type of situation. I just saw a patient today actually who thought she had BII. She had some autoimmune issues going on. She saw a plastic surgeon in Minnesota and had her implants removed, and her symptoms didn't change. So for her, she felt like maybe it wasn't BII. Maybe I really do have something else going on. So it's such a difficult thing to pinpoint when you have kind of a broad array of symptoms that are presenting in vague type ways. And there's so many confounding variables that it's hard to pinpoint, like, this is the thing that it definitely is. I don't know, but I think if somebody has a feeling that they're at their rope's end and they don't have a way to make a good decision, and they feel like the last decision is take the implants out, let's eliminate a variable and see if you feel better. You may not. And I think that's a conversation the plastic surgeon should have is, look, you have to be okay with us taking the implant out and you still having symptoms, because I'm not going to guarantee this is going to fix your problems. And that's a conversation that I have with my patients who feel like the implants are causing issues. I'm like, I don't want to do a surgery that you're not going to be unhappy with, and treat this as like a fix it all type situation. Take the implants out and you're going to be cured. I don't know that's going to be the case, but I will tell you, I have had patients that have had that experience.
Okay. And the overall goal, obviously, is hopefully they will feel better.
Mm-hmm.
And whatever works. And they also have to understand, if you are going to be explanted, this may not be the last surgery. It can't, I mean, there may have to be some fixes. And I know
Mm-hmm.
people who have gone back to New Orleans anyway, that I know of, who have gone back for multiple surgeries for whatever reason. So,
Mm-hmm.
yeah, that implant illness is really an interesting topic. So cosmetic surgery, how does that overlap? I know you talked about like mommy makeovers and things like that. And we breast cancer survivors, we want to make it really clear to everyone out there that, this is not a boob job. This is not a tummy tuck that
Right.
we asked for or
Right. Yeah.
anything like that. Yes, we have options. But this isn't something that I never wanted a boob job. Never in my life have I like, oh my
Mm-hmm. Mm-hmm.
God, I just think, um, that being said, there are some people who actually made comments to me that said, oh, hey, oh my God, that's going to be great. You're going to get your 20-year-old boobs back. And I'm like, yeah, let's
Mm-hmm.
talk about that, because that is not what's
Yeah.
happening here. My breasts are being amputated and, things like that. So how does cosmetic surgery overlap with breast reconstruction? Um, I guess, yeah, I kind of want to go in that direction a little bit.
Yeah. So, my approach to breast reconstruction is, to me, it's all cosmetic surgery. It's all aesthetic surgery. I want it to look beautiful. So, Dr. Kaylee and I, we worked with another plastic surgeon in Ohio State, Dr. Mike Miller, who was actually the chair at the time. But he had this thing that he would say, we would do the micro part. Those of us that do these surgeries frequently, we get to the point where doing the micro part isn't as challenging as it is initially for, like, a starting out plastic surgeon. Initially, people that don't do it very often, like the flap harvest and doing the technical things, that's like, oh, the big part of the case. But what Dr. Miller used to say, and I totally feel this way also, is once the micro part is done, now the case can begin. Now we can do the breast shaping and make it look beautiful. And that's my approach. Is I want my patient to feel like they had a mommy makeover. One of the best compliments that I had is I had a patient that finished her journey. She was at, I think, Victoria's Secret getting bras sized, and the person came in and they were like, "Oh, you look great. You had a mommy makeover." And she's like, "No, I had breast reconstruction." But when she told me the story, she told it with a smile on her face because she looked beautiful. She did look like she had a mommy makeover. And if those of us that do cosmetic surgery and reconstructive surgery, my skill sets in one overlaps in the other, because
Yeah.
my technical, fine dissection techniques help me have less bruising, faster recovery, nicer surgeries for my cosmetic patients. But, transversely, my cosmetic surgery patients, having my hand in that and doing cosmetic liposuction and cosmetic mommy makeover type surgeries, it helps me use those skill sets and those experiences learned in aesthetic surgery to give my reconstruction patients better cosmetic results.
Nice. And I want to be super clear. I think it's great when women go and get mommy makeovers. I know people who have done it, and it's like, it just, uh, they just feel so much better about themselves, and you can see it in their face. You can see it in their step, the way they, communicate. And, excuse me, I've had a cough. See, I was hoping not to cough on this. Um, but so yeah, I just wanted to be very clear that mommy makeovers are great. I mean, but I just that there's a difference between having to do that and going in and doing it just because you want to.
I,
Um,
I have one thing to add to what your comment. You made me think of something. I've had a few patients who choose to have implant-based reconstruction for whatever reason, and they're considering maybe having like a mommy makeover in the future. I will always tell those patients, do not have a tummy tuck and don't do liposuction to the front of your abdomen. You don't want to burn that bridge as a possible option in case you have an issue with your implant. So
oh,
yeah, I tell my patients, like, hey, if you're considering having a mommy makeover or doing something like aesthetic, let's preserve your tummy area. And maybe in the future, if you choose to have your implants removed, we will use that as your tissue option and get rid of the implants. And you kind of get your mommy makeover that way. But you don't want to burn that bridge, because if you do have an implant issue, you really shoot yourself in the foot by getting a tummy tuck.
yeah, that's a really good point. Really, really good point. Wow. Um, hey, what is your experience with men? How have you done reconstruction, or have you done mastectomies on men? And what is that? What is your experience?
So I don't do the mastectomies, but I have treated men who have had mastectomies and are experiencing the same issues that my female patients have. They feel disfigured in their chest area. They embarrassed to take their shirts off, and even going to the pool. I had a gentleman who has a pool in his backyard and was very reluctant to even go swimming in his own pool because he was very self-conscious about the way he felt his chest was disfigured. Typically what we'll do is either like a scar revision type surgery or fat grafting. Some of my patients who choose to go flat, we kind of approach it in that similar fashion where we want them to have a more flat appearing chest wall closure. And for my male patients, that's what I offer.
And how do they feel about that after they're done?
Yeah, I mean, we definitely make improvements in things and help them to feel better about their chest. Absolutely.
That's awesome. So do you have like an oncological surgeon that works in your office that does, I mean, do they work in the same office with you to do the mastectomies?
I'm by myself. I a solo practice, but I have other surgeon colleagues in the community that send me patients, and I work with them. So in San Antonio, there's no general surgery or breast surgery group that's affiliated with a plastic surgeon. They're kind of all independent and or hospital based.
I see. Okay.
Mhm.
Interesting. All right. So thank you. Yeah, I'm so glad we talked about men because I've just been hearing so much more. In fact, I'm going to be interviewing a male breast cancer survivor from the UK here pretty quick. Okay. So we're kind of coming to the end. What ultimately, well, I think we kind of already talked about that. What main piece of advice can you leave our audience with, like anything that, maybe somebody is just diagnosed? What would you tell that patient at that point? And the reason I'm asking is because there are so many of us that don't know what the heck's going to happen.
Mm-hmm.
Like, we don't
Mm-hmm.
know. Like, when I was diagnosed, all I knew is I had to do chemo. We didn't know if I was going to have to do radiation. There was something about surgery in the future. I didn't know what that was going to look like. I've had 2 lumpectomies in the past, so we were hoping that that was what was going to happen. But I did not find out until about a month before, I think it was in November, um, that I had to have a mastectomy on my left breast. That freaked me out. Like, I wish that I would have been able to learn about my options way before that.
Mm-hmm.
So, what kind of advice do you have for people who are just diagnosed and they don't even know what's up?
Yeah. You use resources, do some research, some background research. I always tell patients things that are like .org, .edu, and .gov are usually pretty reputable. So there's kind of a starting point. You want to Google search something. If you find a website and you're like, well, is this, reputable, not reputable? Those are usually pretty good starting points. .coms can be great, but take some information there with a grain of salt if you're not sure. And that at least gives you some information to hang your hat on when you go talk to your oncologist, radiation oncologist, or plastic surgeon. And the other thing I would say is, take notes when you go to your office visits. And if you can, bring somebody with you. Having 2 pairs of ears is better than 1. So there's a lot of times, again, patients, they're overwhelmed. They may be getting chemotherapy. They have, issues remembering things because they're have, that chemo fog that sometimes happens with patients. And if you have a second pair of ears that maybe, caught a piece of information that the patient missed, that's going to be huge. And I think just being your own advocate, is the most
Yeah.
important thing.
I used to take all my husband's notes because he was a really good note taker. We went to my oncologist. I
Mm-hmm.
would take him home, and then I would be the one to develop the post that I put on my private Facebook group based on his notes. Or I'd go live and I would take his notes and go, here's what is happening, because
Mm-hmm. Mm-hmm.
yeah, it's really hard to remember those things, and it's so overwhelming.
Mm-hmm.
Well, and you sound like me as a teacher. If you go to that .com, take it with a grain of salt, because and make sure that you're looking at their references. Who did they source? Things like that. So good job on that learning.
Yeah, thank you.
Well,
I was going to tell you, I had a patient recently. I just did a nipple reconstruction. She's an English teacher, and we were talking about ChatGPT. I'm not sure if you ever had to experience this,
uh-huh,
but she has a lot of
uh-huh.
patients, and she does high school, and she has a lot of issues with people getting information off the internet and using ChatGPT as their resource to write their essays,
Oh
and
yeah.
she's like, when she reads it, she's like, "This is number one. This isn't even correct. Like whatever ChatGPT used as its resources was false or incorrect." But 2, it's just like these kids, they're
Well, and I actually am an instructor for a company that is it's a accelerated program for pre-service teachers to get their teaching
mm-hmm.
degree. Their
Mm-hmm.
teaching, not degree, but certificate.
Mm-hmm.
And they are using ChatGPT. And so I've had to run things through to see if it's, AI. And so, yes, even adults are doing
It's
it.
crazy. Yeah.
Oh, yeah. But I do want to let you know also that there is a very, very good chance that we're coming to San Antonio in July.
Oh, awesome.
Yeah, a whole gaggle of us, because we are making a girls' trip out of getting nipple tattoos.
Oh, okay.
Yeah,
Okay. I probably have an
yeah,
idea of who you're going to see.
yeah, probably.
That's great.
Yeah, so we will keep you posted, and maybe we'll all have to get together and have
I would
some
love that.
dinner or something.
Yeah, I would love
Anyway,
that.
well, I just really appreciate your taking the time to talk to me and being part of, helping educate it, bringing awareness to our breast cancer community. It is my passion. That's why I started this podcast. It is something that I'm just doing in my retirement because of my experiences, and I know what I went through, and I know how, scary it is, and how much I didn't know, even though I knew a lot, but I
Mm-hmm.
didn't
Mm-hmm.
know so much. And I just want to really try to help people who have yet to even be diagnosed. So I just appreciate your taking the time out of your busy schedule and being flexible with me because I've been sick. So, um, anyway, is there anything that you would like to add before we wrap up?
No, you've done a great job, interviewing some great people, Dr. Potter and Dr. Capling. So I'm happy to be included in that group of respected individuals.
Awesome. Well, thank you very much. And I'll see you on Instagram and maybe in San Antonio in 6 months.
Perfect. Love it.
All right. And then to my audience, I really appreciate your joining us with Dr. Garza. And I will see you next time on the next episode of Test Those Breasts. Bye for now.